trying to get your head around one or two things. When you go over it, you do the revision. If you've never studied Addison's disease or you've not sat down to look at Addison's disease, things become clearer to you when you do revision. My friends, Cushing's and
Excuse
Addison's
me.
are
Sorry.
yes, ask question.
Talked about the sick day rules by mentioning those dosages of hydrocortisone.
Those are the things that you need to do when the patient sickness, my friends. When a patient has nausea, they are not feeling fine, they are sick. When an Addison's patient has a major shock or they are bleeding from a major site, they are not feeling fine, they are sick. When a patient has temperature, what does that mean? The patient is unwell. Is it a chest infection? Is it a UTI? Why are they sick? This is why it's called sick day rules. They are rules that are meant for patients who have Addison's disease and are sick. If a 3 or 4 times a day, that patient is not fine, of course. If it's a child, they can go to school. If it's an adult, they can't go to the GP practice and work. You are vomiting 5 times a day. You will call in sick. Why are you calling in sick? Because you are not feeling fine. That's why we call it sick day rules. These are the rules to follow on a sick day. Is that candidate clear about the sick day rules?
Yes, thank you.
Okay, let's go to Cushing's, my friends. Cushing's is too much cortisol. Addison's is too little cortisol. How do you feel questions when things have been made as simple as ABC? I mean, many of you already know these things, but not everybody are on the same level. So I decided to break it down and make it as if you are taking cake and ice cream. Well, Cushing's in the AKT can come in different ways. I like to paint different pictures. Before I give you the acronym, I tell you the commonest way you will see Cushing's in your exam is a patient with a fractured rib. In your mind, that has nothing to do with Cushing's, but in the exam, the answer is Cushing's syndrome. What's that? Osteoporosis. Is a patient that had fallen down. She's a 65-year-old woman who has fallen down. What has happened for years? It's osteoporosis, my friends. In the exam, if you do not know, Cushing's will come up with what we call comedones. The patient will have acne everywhere. That is going to be a year-old female who has never had acne in her life, and she's all of a sudden getting fat. That's what she will say. What's that? Central obesity. Don't fail it in the AKT. Okay, how else can the question come? A 56-year-old patient who is suddenly having what we call ataxia. They are not stable on their feet. What's that? They have an adenoma, pituitary adenoma or adrenal adenoma. They have a tumor. Cushing's presents with sometimes what we call neoplasm is a cause of Cushing's. Well, if you see a young female with a thin arm, what we call proximal myopathy, this proximal myopathy or proximal muscle weakness is not always polymyalgia rheumatica. You may fail it. Proximal muscle weakness or proximal myopathy sometimes can be Cushing's. Don't fail it in the exam. A child that is 7 years that is 3 years old, a child that is 8 years old and looks like a 3-year-old child, stunted growth is due to Cushing's. That is a picture in the AKT. Don't fail it. Can I tell you that in the exam, they can basically tell you about a patient that has got widespread striae and the patient is always falling ill. That is Cushing's. Cushing's is a cause of suppressed immunity. Cushing's is a cause of hypertension. Cushing's is a cause of hypercortisolism. Cushing's can be caused by the doctor, what I call iatrogenic Cushing's. Cushing's is a cause of growth retardation. Cushing's can be caused by medications such as gold, or Cushing's can cause osteoporosis. Cushing's can cause infection, so patients will be predisposed to infection. Cushing's is a cause of hyperglycemia. That's what we call diabetes mellitus. Cushing's can cause low mood. My friends, if you see a low mood question and the low mood question at the end of the day is talking about a patient that has moon face, how do you fail it? It's Cushing's. Well, let me just make it easy for you. I've told you more than 18. If you have not been listening, I've called more than 18 presentations how Cushing's can come. It can come in any way. This is when I tell you that they can drag you dirty. When they are dragging you, they are pulling your shirt, the AKT is pulling your shirt, hit his hand away, tell it, go and sit down. I've got you under control. Give it his medication to sit down. His medication is knowledge. When you have the knowledge to tackle the AKT becomes humble. But when you don't have the knowledge to tackle the AKT, it taunts you. You can't sleep at night. It gives you nightmares, my friends. You cannot afford to have nightmares. You are supposed to make the AKT scared. You are supposed to be the one giving the AKT anxiety. No Cushingoid map, my friends. What is Cushingoid map? It's something I've said almost 8 times. It's a popular acronym. It's not hidden. It's on the internet. Well, if you see Cushing's syndrome, think about central obesity as C. Think about comedons. I've talked about it. Think about cataracts, my friends. Okay, if you see U in Cushingoid map, think about the urinary free cortisol. Think about ulcers, my friends. Well, if you see S in Cushing's syndrome, striae. Striae is S in Cushing's syndrome. Suppressed immunity is S in Cushingoid map. Well, again, if you are looking at it, the H there can be hyperglycemia. But the most important H in Cushingoid map is hypertension. How do you feel these things? Hypercortisolism is the main problem in Cushing's. Too much cortisol. And I've put it there in the acronym for you. Well, in the eye of Cushingoid map, that is iatrogenic. Is that doctor that is feeding his patient with steroid. That's why I said, if I have not taught steroid, I have not taught endocrine. Neoplasm, I've told you, if you see pituitary adenoma, it can be Cushing's. If you see adrenal adenoma, it can be Cushing's. How do you fail it when the whole thing about Cushing's is that you know that it causes glucose intolerance? I've said it in 3 ways. Now, glucose intolerance has come under H, hyperglycemia. Glucose intolerance has come under D, diabetes mellitus. Why am I repeating it? That's one of the commonest pictures that Cushing's will present with in your AKT. I decided to repeat it in the acronym 3 times. How do you feel these things? My friends, again, in the AKT, they can talk about growth retardation. That's one of the G in Cushingoid map. They can talk about a trigger, gold. Gold is a trigger for Cushing's. Don't fail it in the exam. Well, the O in the Cushingoid is osteoporosis. Everyone should know that. Well, the I in the Cushingoid, think infection, my friends. They are prone to infection. Why? Steroids. Steroid lowers their immunity and predisposes them to all sorts of infections. In Cushingoid map, the D is diabetes mellitus. The D is depression. The question will come as low mood. In Cushingoid map, the M is moon face. So if you see a patient with a rounded face some candidates will be waiting for them to talk about moon face. You will not see it. They will say the face of the patient looks round. How do you feel these things? A in Cushingoid map is the arm is thin. You see the arm of the patient looking very thin. I've given you a picture. It's always a young girl. She's 16. Her arm is very thin. That's how she is, but she's got Cushing's. The P there, I've told you, is proximal muscle weakness, which you can also see in polymyalgia rheumatica. Anyway, I decided to add an S to the Cushingoid maps just to tell you that stunted growth can be a picture in your AKT. How do you feel these things? So my friends, Cushing's disease, look at the moon face in this lady. How do you want to feel it? They've covered her eyes because she's got cataracts. Play with these things. If they decide to show us her whole body, she's got central obesity. Don't fail it in the exam. So, well, I've given you a picture. I won't be held liable for not giving you a picture of how Cushing's will come in the exam. I've even increased it to 20 points that it can come with. If you know all the 20 points using Cushing's, they can't drag you dirty. If they push you left, you go with them left and you don't stagger. If they try to push you right, you follow them right, you don't shake. When they see that they are trying to move you up and down, you are not moving, they leave you. They go to another candidate who has been sleeping. Okay, now that we know the picture, this is something I like to personally teach myself. I don't like any other teacher teaching it because I need to tell you the types. In the AKT, Cushing's disease, Cushing's syndrome can come in different form. Well, I tell you, if you see a patient and their Cushing's disease is because they have what we call pituitary adenoma, that means it's a tumor that is producing too much ACTH. And this too much ACTH is leading to too much cortisol. What is that? I term I use a word called brain wahala. They have a brain problem. So Cushing's disease is brain wahala. How do you fail it in the exam? It is simply a tumor in the brain or in the head that is producing too much ACTH. That is a brain wahala. That is the first type of Cushing's type of Cushing's that you need to know. Cushing's disease. So Cushing's disease producing pituitary adenoma producing too much ACTH. That's Cushing's disease. What is the second type of Cushing's you need to know? Is what we call iatrogenic Cushing's. I've just talked about it. It is that GP that is loading his patient with too much steroids. Was it? That steroid is lasting at least over 3 months. It has to be greater than 7.5. Some candidates don't know if what I've just said to you didn't ring a bell, or you don't know what I'm talking about, you have not started studying, my friends. That is because prednisolone 40 milligrams for chest infection cannot cause this. That's because 3 days asthma prednisolone cannot cause this. But what can cause this? Long-term steroids. That's what I was trying to tell you. It's greater than 7.5 over 3 months. You're dealing with long-term steroids. What's that? Polymyalgia rheumatica. What's that? I'm talking about rheumatoid arthritis, my friends. I'm talking about conditions where we need to give steroid long-term. My friends, please and please don't go to the AKT without having knowledge at your fingertips. Knowledge at the faces of your books is useless. Knowledge hidden in your brain, you may fail the exam because at the point of trying to bring it out or extracting it from your brain, you may be too slow. You may fail the exam because of time. But knowledge at your fingertips is disposable knowledge. It is easy to dish out. Sometimes you give them overdose. You know too much. And that's why the candidate can get 95 in the AKT. Well, let me leave iatrogenic Cushing's. Now that you know that iatrogenic Cushing's is what I call Dr. Wahala. So you know brain wahala, you know Dr. Wahala. Brain wahala is brain problem causing Cushing's disease. Doctor wahala is doctor problem causing iatrogenic Cushing's. That's the doctor is feeding the patient with too much steroids. Can I give you a third type of Cushing's, my friends? I call this one kidney wahala, kidney problem. Why? It is because the adrenal gland has a tumor in it, what we call adrenal adenoma. Well, adrenal adenoma means that the tumor will be producing excess cortisol. How do you feel it now that I've made it this easy? I've told you that kidney wahala is adrenal, doctor wahala is iatrogenic Cushing's, and brain wahala is Cushing's disease. How do you want to fail it? I beg of you, nobody should fail a question on Cushing's disease. Even if you don't tell me, I will be pained. Don't, please. If you don't let me know because you are ashamed, if my conscience tells me that one of you have failed the question on Cushing's, I won't be happy. I will be moody that day. I won't know why I'm moody because you failed a question on Cushing's. Don't fail it, please. I beg you. I've made it too easy for you to fail. So the first thing is the picture, Cushingoid map. I know someone has written a full page of Cushing's now that I'm talking. Don't do that. What you should have written maximum is 2 lines. Line 1, picture, Cushingoid map. Line 2, types. That's where you write doctor wahala, brain wahala, and kidney wahala. The only last one I've not talked about, which I want to talk about now, is paraneoplastic Cushing's. Paraneoplastic Cushing's. Well, it has a wahala as well. It is long wahala. I will explain. Paraneoplastic Cushing's is excess ACTH from an ectopic site. That means this is a site that normally does not produce ACTH. It's normally not supposed to ACTH. For the purpose of this exam and the purpose of this teaching, and even if you are here, so because I know there are 1 or 2 candidates that are here because they are writing the Canadian exam, the QE1. If you are here because you are writing the Canadian exam, for the purpose of that exam, let me tell you, there's only one thing you need to know. Small level of information you need to know for paraneoplastic cushion. Every other thing is inconsequential. Every other thing is for a professor. Every other thing is for a trainee in internal medicine. You don't need to know it. And I'm telling you 100%, small cell lung cancer is the commonest cause and the only amplified cause of paraneoplastic Cushing's. Don't fail it in the exam. What does this small cell lung cancer, what will it do? It will start to produce ACTH abnormally. Well, if it starts to produce ACTH, what will happen? The patient will have Cushingoid mark, my friends. So how does it work? The small cell lung cancer, of course, is in the lung. It's producing too much ACTH. This ACTH is going to produce too much cortisol, and it produces Cushing's disease. And Cushing's disease will bring out Cushingoid mark, which are the symptoms of Cushing's disease. So this is why I call it lung wahala. Lung, the lungs have got a problem. How do you feel it? So on that second line, write brain wahala, write doctor wahala, write lung wahala, write which one have we missed? Kidney wahala. That's all you need to write on the second line. It also is a way to exercise your brain. Some of you are causing your brain to be lazy, what I call the lazy brain syndrome. How would you write a page on Cushing's? Then what do you want your brain to do? Nothing. Your brain knows. So what you have told your brain is, for if it's Cushing's, it's on the third page in my jotter. That's the only thing your brain will know. You are planning to fail the exam if you are doing that. Please, it's self-harm. Allow it to be on the pages of your brain by only coding it with names of things that you would use to remember a starting point. So when I call a candidate during the drill period, I tell me about the doctor wahala. The patient says, well, is that doctor, is that GP that gives too much steroid? I say, okay, now that you know that one, tell me about kidney wahala. You say, well, it's a tumor that is an adrenal adenoma that is producing too much cortisol. I say, okay, I know you know that one, but the one you will not know is lung wahala. You tell me it's ectopic ACTH. I become proud. I become very happy. It means we have not wasted the teachings. So, well, those are the types of Cushing's. I don't expect any of you to fail Cushing's in the exam by not knowing the types, by not knowing the picture, but they can ask you the investigation. I've basically said the investigation before time because I wanted it to be repeated. Some people think, well, why is it saying the investigation when we are still going to do Cushing's? It is deliberate, my friends. If you hear it 2 times, then the likelihood of failing it is low. If you hear it 3 or 4 times, it means if you fail it in the exam, you deliberately failed it. I can tell you that. If you hear that the dexamethasone suppression test is the test we do in the AKT in secondary care, and 24-hour urinary cortisol is the test we do in primary care, you're hearing it for the 5th time, and you go to the AKT and you fail it, is deliberate. If you heard it for the second time, well, you can fail it, the chances are slim. But if you heard it only once or you read it only once, there's a high chance you can fail it. If you've never read it at all, of course you will fail it. My friends, please see these techniques, see these systems, see how they work. Sometimes I spend more time on the systems rather than on the topics because I know once you grasp the system, you've passed the exam. How did I know? I have studied candidates that got 95. I've studied candidates. There's a candidate around me now. He scored 92 in the AKT. He didn't join the Easy Learn class, but when it was time for his AKT, he asked me a few questions. I said, this is how to do it, this is how to do it, use this system, use this system, use this system. He came back to me. He said, Dr. Ola, I scored 92. I first hugged him. He said he wants to take me out for a lunch. I said, well, I'm very busy. He said, well, we'll make it a dinner then. He forced me. We went for a dinner to celebrate his AKT. But that was not it. During his AKT, as we're having some dinner together, he said, do you know the only thing that helped me in this exam to achieve 92 is the systems. This is not the first time I'm hearing about the systems. And that's why sometimes if you look at the teaching, it's 70% teaching, 30% telling you about the systems. The systems work. Clinchers work. Cliches work. Rather than teaching, I could have taught Cushing's as a topic and go away. I'm pointing out the things that they will ask in the exam. I'm pointing out the things you need to look at so that you can answer the question in 10 seconds. They work. They don't just work. They are the only ones that can make a candidate score 95. Any candidate that has got 90 and above, I know why. They've used the system. The system is the same. Whether you've used it in Ireland, Wales, Scotland, is the same, my friends. So please use the systems. The system of repetition is key. That is why we've designed this course to have drills for repetition. After teaching, we drill you again. After drilling you, we drill you again. After drilling you, we drill you again. There is no last time drilling. The drilling continues up until your exam day. Sometimes in some candidates in the last quarter, some candidates will remember that even the day before their exam, in the midnight of their exam, we were still doing drills. So some candidates will remember that even when we're doing it, sometimes 2 a.m., we went on drilling. We didn't stop drilling. This is how you need to do it. Okay, so now that you know that dexamethasone suppression test is secondary care, and you know that 24-hour free urinary cortisol is primary care, I'm not going to discuss this in full details because you don't really need it. You are not a medical internal medicine trainee. But if you want me to describe it to you, please join the drills and we can talk about that. We got enough time during the drills to go into how this test work. Well, the only other thing I want to tell you is, if I want to just describe the dexamethasone suppression test briefly, I'll tell you that it is taken at 10 p.m. and your result is checked at 9 a.m. the next morning. It's unlike the 9 a.m. cortisol that is taken at 9 a.m. and checked at 9 a.m. This is taken at a night before. So the dexamethasone suppression test, this is another difference. It's taken a night before the test and the result comes out in the morning. But 9 a.m. cortisol is taken in the morning and the result comes out in the morning. There is a question that they can ask in the AKT. What question is that? They can basically ask you, why are we doing 9 a.m. cortisol? Why is it not 3 p.m. cortisol? It is because of what we call diurnal variation. Cortisol is not the same all day round. 9 a.m. will be the same every day, but when you go to 3 p.m. and compare 3 p.m. to 9 a.m., you start to get mixed up. You start to get muddled up. You start to get a wrong result, my friends. So what you need to do is 9 a.m. cortisol. If they put 10:30 a.m. cortisol, is wrong, my friends. 10:30 a.m. is too late. If it's 2 p.m. cortisol, you fail the question. If it's 6 p.m. cortisol, you cannot get that question. How do you fail it? Now that I've told you it has to be 9 a.m. and only 9 a.m. Well, I didn't want to talk too much about the investigation and diagnosis, but something just popped into my head. In fact, many things have been popping into my head. I've been trying to suppress it. I will try to suppress as much as possible because endocrine has too many things. But let me say this, pardon me to say this, if we are talking about dexamethasone suppression test, they can ask you about the 1 milligram test and the 8 milligrams test. The 1 milligram dexamethasone is given when you are just trying to check for Cushing's syndrome. You want to see if cortisol is high on the lower centers. But when you want to differentiate the different type of Cushing's, you need the 8 milligrams one. Well, I'll talk about that when we go to the drill. Let me not confuse anyone. Can we move on? My friends, they can basically ask you the management. They can leave picture. They can leave the types. They can leave the investigation and diagnosis. They can drag you. They say, my friend, come and answer question on management. Let's see whether you are good. This is where easy learn candidates shine. This is where easy learn candidates tell them they are very good. By the way, I know some of you are here. If I ask you about ketoconazole, if I ask you about the 360 degrees of ketoconazole, some of you will say, well, it's an antifungal agent. You people will tell me the class. Some of you say, yes, it's used for this, used for this, used for this, used for this. By the time I challenge you and say, do you know it's used as a treatment for Cushing's? Quite a lot of you don't know. My friends, ketoconazole is a medical management for Cushing's. Don't fail it in the exam. Ketoconazole is a specialist treatment for Cushing's disease or Cushing's syndrome, sorry. Cushing's disease treatment is surgery because it's a tumor. So how do you fail it? Cushing's syndrome treatment can be ketoconazole if it's any of the other causes. But once it becomes Cushing's disease, because it's a tumor, the answer in the AKT is radiotherapy. The answer in the AKT is surgery. The answer in the AKT is chemotherapy. Don't fail it in the AKT. Don't go and choose ketoconazole when they're asking about Cushing's disease, because Cushing's disease is brain wahala. Brain wahala means there's an pituitary adenoma causing excess production of ACTH. That medication won't work. Remove the tumor. That medication won't work. Shrink the tumor. That medication won't work. Use chemotherapy, my friends. Can I just announce to you that if you are using the medical management for adrenal Cushing, what I call kidney wahala, you've also failed the question. Why? It is an adrenal adenoma that is producing excess cortisol. How do you fail these things? The patient just basically needs surgery. Do surgery, remove the tumor, the patient is fine. In the meantime, you can't remove the tumor. It has become too big. It's in a dangerous angle. Do radiotherapy. How do you fail it? Well, if I to announce to you that ketoconazole is not the only treatment, there's a medication called metirapone. Metirapone, the brand name is metopinone. If you see metopirone in the AKT, they are talking about metirapone. They are medical management for treatment of Cushing's. So if I go around Cushing's 360 degrees, I don't think anybody should fail it. The amount of points I've left out of Addison's, they are not much. I've left out points that are not serious. I've left out points that I think they will never be able to ask you. But have I left it out of this program? The answer is no. I will ask you in the drills. We will talk about it in the drills. So in this course, you may think, oh, the teaching is incomplete. He has taught 90%, but there's still a 10%. The 10% is not missing, my friends. It's in your drills. This is why you need to attend the drills to be a complete doctor. Ready for the AKT. The drills are super high yield. Can I beg you, don't miss the drills and the mock. If you are listening to us online, you're not part of the Easy Learn family, please, you can continue your program, but join the mocks. We'll give you a review, we'll give you feedback about AKT. If you know you're writing the AKT, you're writing in October, do the mocks. Is a test, wherever you are, is a test whether you are doing well or not. We'll give you a feedback report. For the drills, please, if you have paid for it, you are wasting money. But beyond that, you are wasting money. That is the only way to cement the knowledge. How do you hear these things one time and you go for the exam? I've told you are likely to fail the question. Hear it 3 times. Hear it 5 times. It's not too bad if you hear it 5 times. Okay. I think because of time, let me just move away from Cushing's. I know some of you are getting tired. So what we can do is to do cones. If you are not too tired, we can do hyperparathyroidism and take a break, or after cones, we can take a break. So let's go to cones. Cones is not too big. Cones is not anything to worry about. Just have it at your fingertips. You will pass the question. So Crohn's disease, I give you a picture of a patient who is about, let's say he's in his 40s, and this patient is basically having hypertension. Well, that can be Crohn's or Cushing's. That hasn't helped. You continue to read on, you see that he's having hypokalemia. My friends, that can be Crohn's or Cushing's. That hasn't helped. So you need to read on. So what do you now read on? You continue to read on and you see that that patient is gained weight and has a BMI of 43. My friends, that's not Crohn's, that is Cushing's. That is a way to differentiate it. You look out for Cushingoid maps, you see any of them is Cushing's. You don't see any of them, start to think about Crohn's. That is the first way to know Crohn's. If you start seeing that they are talking about, most likely everywhere in the question, you are seeing aldosterone, and aldosterone, my friends, they are talking about Crohn's. But the classical picture of Crohn's disease is a patient with muscle weakness. It presents a bit like Addison's. The patient is tired all the time. How will Crohn's present? With headaches. How will Crohn's present? The patient will be thirsty. It is like diabetes insipidus. By the way, I forgot. Please, diabetes insipidus and SIADH tomorrow. If you miss out tomorrow's class, listen to the video or listen to the audio book. SIADH will turn up in your exam. If it doesn't come out, diabetes insipidus will come out. Sometimes both of them can come out. If you don't see one of them in your exam, come back to me. Say, Dr. Ola, it didn't come out in my exam. You say it was going to come out in my exam. I'll give you £20. Come back. I promise you, I'll send it to your account. You will see it. And that's why I'm going to teach it tomorrow. Well, let's go back to Crohn's disease today. You see a picture, the patient has got hypertension, the patient has got hypokalemia, but he's got muscle weakness. He's got tired all the time. He's got headache. He's very thirsty. He goes every night. He says, "Doctor, I've been peeing a lot." If he's a man, check his PSA. Do a back passage examination. If his prostate is rough and craggy, is a 2-week wait. If you examine the prostate, it's smooth, but the median sulcus is distorted, is a 2-week wait. If it's enlarged and smooth, normal median sulcus, think BPH. If the man has a normal prostate, nothing to worry about. PSA is normal. Please check the urine dip. Men can have UTI, my friends. If the man is peeing a lot and is not only at night, is during the daytime, it can be diabetes. Please do HbA1c. It can be diabetes mellitus. It can be diabetes insipidus. The difference between diabetes mellitus and diabetes insipidus is that one is glucose, the other one is antidiuretic hormone, ADH. How do you fail these things in the exam, my friends? Well, let me not divert because I'm teaching that tomorrow. Crohn's disease can cause paralysis, muscle weakness. Don't fail it. They say, man, he's just suddenly feeling very tired and he's got muscle weakness. It's Crohn's when he has hypotension and when he has hypertension and hypokalemia. You can't fail it in the exam. Okay, so that's the picture of Crohn's disease. That's how it will come. I've given you the picture. I've told you how it will come. Don't fail it in the exam. But what is the most important thing? The picture is how the question will come. That's not the answer to the AKT. The answer is how to know what they are asking you in the exam. Well, I put differences here because I wanted that you to be able to differentiate between Crohn's and Cushing's. And by now, I think I've run my mouth too much on the differences. No one should feel the differences. But let me just move into what they want you to know. Investigations. Can I say something before the investigations? There is what we call primary Crohn's, secondary Crohn's. Let me just say that carefully. Adrenal adenoma secreting aldosterone is primary hyperaldosteronism. Do you know how I said Addison's disease is too little cortisol? Cushing's disease is too much cortisol. So what is Crohn's? Crohn's is too much aldosterone. Look at that. One is too little cortisol. The other one is too much cortisol. The third one is too much aldosterone. This is when you have to know the renin, angiotensin, aldosterone pathway. I'm not doing pathophysiology. If during the drill someone is really confused, I can go into it. Pathophysiology, the last class, in the last cohort, I taught it. I made sure that they understood the pathophysiology of Cushing's. I made sure that they understood the pathophysiology of Addison. I made sure that they understood the pathophysiology of Crohn's. But my friends, it doesn't come out in the exam. If you want to learn the pathophysiology, it's good. It will help you. It will improve your knowledge. And it will help you navigate this question more easily so that you don't have to cram. But these things are bread, they are biscuits, they are bread and butter. And so I've decided not to delve into that. It will waste our time. And we've got just limited time. So my friends, if you see a patient that has high aldosterone in the question, start to think about Crohn's. Primary aldosteronism is Crohn's. Secondary is not. That's why I say we've got two types. When you start to see a patient that has primary hyperaldosteronism Crohn's, you need to think, why is he having it? It can be a tumor. Most times it's an adrenal tumor. Let me say that again. Simple adrenal gland producing too much aldosterone is usually because of a tumor. So if you see the adrenal gland is producing too much aldosterone, think about an adrenal tumor. That is the cause. That is the likely cause of Crohn's. However, there are other things. How do you remember the other things? I've decided not to put too much codes here because our codes, we learn them during the drills. The last class, they learned about 12 codes. They learned all the codes. They learned codes, and we're going to learn it in this afternoon. Some of the codes we're going to learn them this afternoon. So please, if if you are not in the past plus, don't miss too many weekend afternoon drills because they will be repeated only twice. Okay, so FAB is the acronym to remember the other causes of primary hyperaldosteronism, what we call Crohn's disease. What is FAB? I'll tell you. Familial hyperaldosteronism is F. Adrenal carcinoma is A. And local causes, which will be usually bilateral adrenal hyperplasia, will be the P. Let me repeat what FAB is. FAB are the causes of primary hyperaldosteronism, what we call Crohn's disease. F, familial hyperaldosteronism. A, adrenal carcinoma. And B, bilateral adrenal hyperplasia. Please don't fail it in the exam. I've put this code so that things can be easy. If you remember without the code, all fine and good. It will come in your 120 page or whatever page notes that you are getting. You will see it there. Well, I just thought I should mention a bit about secondary hyperaldosteronism. I said I'll just say that to you. Well, renin is the problem here because it's whenever you hear primary, it's a local cause. Whenever you hear primary, it is from the affected organ. But when you hear secondary, it's from an external cause. Usually, I call it central causes. It's usually from the brain. If you hear it's not from the brain, it's not from a local cause, it's just from another part of the body, then it becomes ectopic. How do you feel these things? Ectopic pregnancy means pregnancy in another part of the body. Ectopic ACTH means ACTH produced from another part of the body. So you can bring up your own cones. Ectopic cones will be aldosterone produced from another part of the body. Well, there's really nothing like that because it's usually either a central cause or it's a local cause. So what is the central cause here? Is usually what happens is that renin is so much. It starts to stimulate the adrenal gland to produce too much aldosterone. And you know our problem. Our problem in Crohn's is too much aldosterone. Aldosterone excess. That's why it's called hyperaldosteronism. Don't fail it in the exam. Why is renin too much? Because there is a positive feedback producing so much renin, because what is happening is that the organ or the gland is telling the brain, look, there's no enough cortisol, but it's a wrong signal. That feedback is wrong. And so what does the body do? The body starts to push all the hormones, and then finally they produce too much renin, and too much renin produces too much aldosterone. But well, I know you understand that, so I'm not going to go too deep into that. Please, the causes is what I want to tell you about. If you don't know any of the causes, know two causes. In fact, I'll tell you only two causes. Why? They are important for your QE1 and they are important for your AKT. Renal artery stenosis is a key cause of Crohn's. The other one will be renal artery obstruction. They are different. Stenosis is narrowing of the renal artery. Obstruction is blockage of the renal. How do you feel it? Obstruction, there's a blockage of the renal artery. Narrowing, there's a thinning of the renal artery. Don't fail these questions in the AKT. Okay, so now that we've talked about secondary, let me quickly run. We've talked about secondary. We've talked about the picture. What is the investigation? I thought I should mention that before I go into the investigation, because if you know the causes, the investigation will be easy. The picture is clearer. So if you've got a tumor, an adrenal tumor producing aldosterone, how do you investigate? CT MRI, my friends. If your problem is renal, how do you investigate? This is where you do CT angiogram because it's a vessel. But the other major investigation, which is the first line investigation, is to check renin aldosterone ratio. Don't feel it in the exam. Renin aldosterone ratio, if you have not been listening to me, will be the first line investigation in a patient with Crohn's, not CT, not MRI, not CT angiogram. Some candidates will fail it, and that's why I decided that I will talk about it last. So, gold standard investigation, renin aldosterone ratio. Most important investigation, renin aldosterone ratio. Primary care investigation, renin aldosterone ratio. Secondary care first line investigation, renin-aldosterone ratio. Sometimes with the renin-aldosterone ratio, you don't even need to go far. Sometimes you don't need to do CT. It depends. If you suspect that the cause is a tumor, adrenal tumor, you can do your CT or MRI. If you think that it is due to the vessel, the patient is having symptoms of renal artery stenosis, you've given ACE inhibitor, the patient has collapsed. I taught that in cardiology. When do you not give ACE inhibitor? Don't give ACE inhibitor in renal artery stenosis. They will collapse. They will collapse. Don't give ACE inhibitor in aortic stenosis. They will collapse. I told you guys. Where else should you not give ACE inhibitors, my friend? Don't give ACE inhibitor with aprostadil. That patient will be in A&E. They will message you. If a patient is on sildenafil and you are giving ACE inhibitor, GMC will knock on your door. I've told you before. Don't do that. Well, there's a candidate in the AKT. The question will clearly say that this patient is using 80 milligram fusimide. That candidate will still rush and give ACE inhibitor. Well, you want to go to a GMC tribunal. Maybe you've never seen it before. The patient will be in A&E. Don't do that. And knowledge helps you to know the things you are not supposed to do. So that patient with renal artery stenosis, you can do CT angiogram just to confirm. That patient with renal artery stenosis, renal artery obstruction, CT angiogram or CT will help. So that will be the two investigation for this patient with Crohn's disease. How do we manage? Manage is based on the cause, as you may have noticed. If there's a tumor, do surgery. What are you doing? Just do a surgery and take out the tumor, and the patient will be fine. So management, tumor, remove adrenal tumor or remove adenoma, the patient is fine. But if it is not due to a tumor, what do you do? The only answer in the AKT is aldosterone antagonist. Don't fail it. Sometimes I leave the best for the last. You can say I start with surgical removal of an adenoma because I don't want to emphasize on that. I know everybody that sees that the cause is due to a tumor, they will go for surgery. The same thing in Cushing's. If the cause is a tumor, the treatment will be surgery or radiotherapy. I've overemphasized it. The only time you go for ketoconazole, which is a medical management, is if it's a medical cause. And before, so some candidates will just rush and go and give ketoconazole in the AKT. You will fail the question. Why? The first line treatment for Cushing's disease is to manage the cause. So if you are giving a patient high dose steroid for 6 months and you chose ketoconazole rather than stop steroid, you fail the question. I don't know if that's clear to someone. Okay, so aldosterone antagonist is your answer for Crohn's disease, medical management, and it to be your first line. If you have been in this easy learn for the last 4 weeks and you've not heard me say aldosterone antagonist at least 3 times, you are unfair to me, my friends. I basically said it even in June when we were doing the charity course. I came back in August when we were doing cardiology. I told you first line, beta blocker or ACE inhibitor. If ACE inhibitor, the patient cannot tolerate ACE inhibitor for some reason, try ARBs. If that's not working, move to second line. Second line, I said, is aldosterone antagonist. I said aldosterone antagonist is spironolactone. I said aldosterone antagonist is eplerenone. How do you feel it in the exam? My friends, again, whenever you go to heart failure, please look at the ejection fraction. The ejection fraction is above 40. The answer in the AKT is fusimide. If it's below 40, that's when you start to think, is it ACE inhibitor? How do you choose whether it's beta blocker? Has your patient got asthma? If your patient has got asthma, your answer is ACE inhibitor. If your patient has got renal artery stenosis, your answer is beta blocker. Which beta blockers do you want to use? Is CBN, carvedilol, bisoprolol, nebivolol. How do you fail these things in the exam? My friends, I just thought I should just go, because I've told you learning is a little here, a little there. I know we've done cardiology. I know I've overemphasized on heart failure. The only thing that decided to put it there is because that will be your number 3 question in the AKT. You will see it. Trust me. If you don't see it again, this is another 20 pounds for you. Come back, say, Dr. Ola, I didn't say a question on heart failure. I've come to collect my 20 pounds. I will give all of you 20 pounds. Okay, my friends, that is Crohn's disease. I don't want us to just stay on things that are very easy. I don't believe that one of you will fail a question on cones. It's not easy learn. If they say a candidate failed, I will say, well, that candidate, I'm very sure is not from easy. I can hold my head high. This is how you have to hold your head high. You need to be proud. When you are going to the exam, you need to be proud. Show AKT you are proud. Other people they are flipping pages on the exam morning. You just take a cup of coffee and relax. Go on TikTok. Go on Facebook. Go and play in the morning of the exam. Relax. Stop reading. Other people are saying, oh, what's the cost of secondary cushions? There's a shop beside your exam hall. They've got a bit of ice cream. It's about 10 o'clock. You feel like taking ice cream. Take the sugar. Relax. Don't join them to go and be flipping pages. That is the wrongest time to flip pages. 1 hour before your exam. Don't do it. Flip the pages today, my friends. And this is why I know that all of you can pass the EKT, because you're already flipping the pages. Please continue to flip the pages. Don't flip the pages and leave the information on the pages alone. Flip the pages and leave the information on your brain. Don't have brain wahala, my friends.